Hi, it's Dr. Renee, and today we are having a webinar with AstraZeneca about allergies and asthma. And our guests are Dr. Autumn Burnette. She is the assistant professor in the Division of Allergy and Immunology at Howard University in Washington, D.C., and Dr. Michael Lenore, who has been on many times and who's an allergy and immunologist out of the Oakland, California area.
Hello, and welcome to this program sponsored by AstraZeneca. My name is Dr. Autumn Burnette, and I've been practicing medicine as an allergist in the asthma space for approximately 15 years. I have the pleasure of providing this educational disease state presentation entitled, Taking Control, the Urgent Need to Identify and Address Uncontrolled Asthma. Please note that this presentation does not qualify for any form of continuing education credit. Today, our goal is to achieve the following objectives: recognize the burden of uncontrolled asthma in the United States, learn how the AIRQ, pediatric AIRQ, and accompanying evidence-based educational materials can help identify uncontrolled asthma, and heighten the awareness of patients and clinicians' overestimation of asthma control and evaluate the clinical merits of AIRQ and pediatric AIRQ compared to other asthma control tools. Let's begin by looking at asthma prevalence in the United States over the last 2 decades, which we see has remained relatively stable. In 2022, approximately 26.8 million people in the United States had asthma, accounting for approximately 8.2% of the country's population, which is a slight increase from previous years. Based on the most recent data, approximately 44% of children and 60% of adults live with uncontrolled asthma. A substantial portion of U.S. patients with asthma remain uncontrolled, contributing to increased healthcare resource utilization and reduced quality of life. The latest statistics on asthma show that in 2022, there were approximately 11.4 million asthma attacks in the United States, while there were over 3,500 asthma-related deaths in 2021. In 2020, there were approximately 1 million emergency department visits and approximately 95,000 hospitalizations due to asthma. And in 2018, there were more than 7.9 million missed school days and 10.9 million missed work days due to asthma. The burden of uncontrolled asthma is substantial and projected to increase in the next decade and beyond. Projections from 2019 to 2038 estimate that approximately 2 million more individuals aged 15 years of age and older will be living with asthma by 2038, with 52% of all patient years with asthma are expected to be uncontrolled over this time period. Over this 20-year period, cumulative projected cost associated with uncontrolled asthma, both direct and indirect, will be close to $1 trillion. These projections suggest that new approaches to the identification and management of uncontrolled asthma are needed to help decrease the burden of disease. When it comes to assessing asthma control, measuring only symptom impairment or only exacerbation history-based risk may lead to misclassification of disease control for a significant portion of patients with asthma. Both domains of control need to be assessed to properly understand a patient's disease control status. In a large study looking at medical claims data in approximately 4.5 million patients of all ages and all asthma severities, patients were characterized by both domains of control, impairment, and risk. Those who had 2 or more annual systemic corticosteroid fills were considered uncontrolled by the risk domain. Those who had 3 or more annual short-acting beta agonist fills were considered uncontrolled by impairment alone. When assessing disease severity using risk alone, 14% and 23% of patients with mild, moderate, and severe asthma, respectively, were identified as uncontrolled. On the other hand, when assessing disease severity using impairment alone, only 28% of patients with mild to moderate and 39% of patients with severe asthma were identified as uncontrolled. However, when using both domains to define control, 35% of people treated for mild and moderate asthma and 50% of people treated for severe asthma had uncontrolled asthma. Of the approximately 1.7 million patients identified as having uncontrolled asthma, 81% were treated for mild or moderate disease. So what does the GINA expert report recommend for measuring asthma control? According to GINA, asthma control should be measured in two domains: symptom control and risk of adverse outcomes. Symptom control is important to measure in patients with asthma. However, it should always be measured in combination with future risk. Clinicians should always strive to identify risk factors in their patients, including exacerbations, accelerated lung function decline, and medication adverse effects. Today, healthcare clinicians face many barriers with asthma management. Some examples of barriers to implementing optimal asthma care include the following: lack of time and staffing, particularly in busy primary care offices, limited access to a multidisciplinary team for asthma care, and patient-related barriers such as insurance, patient adherence, and knowledge gaps. However, many of these challenges can be addressed through coordinated efforts, such as including the proper implementation of validated asthma control tools into their practice, particularly those which measure exacerbation history-based risk. Interestingly, there's also a poor adoption of validated asthma control assessment tools, which leads to a lack of adequate assessment of asthma. Even if these tools were implemented into practice more regularly, most of the commonly used tools, such as AIRQ, which is Asthma Therapy Assessment Questionnaire, and ACQ, which is Asthma Control Questionnaire, and ACT, which is Asthma Control Test, and the Childhood Asthma Control Test, which is CACT, these do not measure prior year exacerbations, a metric which GINA suggests for assessing a patient's asthma control and future risk of exacerbations. To help address the urgent unmet needs in asthma, the Precision program was developed. The Precision program is an unbranded initiative dedicated to improving the identification and management of patients with uncontrolled asthma. The program was developed in conjunction with independent advisors, including scientific and clinical experts and local healthcare professionals representing different backgrounds, specialties, and geographic locations, and even practice settings. The pioneers of the Precision program set out to accomplish a variety of objectives, including the following: developing and validating an asthma control tool that measures both symptom impairment and exacerbation risk, providing evidence-based clinician and patient education materials, publishing data on the efficacy and implementation of developed tools and materials, and partnering with societies and healthcare systems. Through this program, a composite asthma control tool for adults and adolescents aged 12 years of age and above was published in 2020, and a composite asthma control tool for children aged 5 to 11 years was published in 2025. We will go more in-depth on the use and validation of both composite control tools in the upcoming slides. The AIRQ is a 10-item, low literacy demand, equally weighted yes-no composite asthma control questionnaire with 7 impairment items with a 2-week recall period and 3 risk items with a 12-month recall period. It includes exacerbation items that represent a significant component of asthma morbidity that are currently not captured in many existing questionnaires. AIRQ scores are interpreted as follows. Scores of 0 to 1 indicate well-controlled asthma. Scores of 2 to 4 represent not well-controlled asthma. and scores 5 to 10 identify very poorly controlled asthma. The AIRQ is designed for healthcare professionals to use with their patients 12 years of age and older who have been diagnosed with asthma. This composite control questionnaire is meant to be used within a clinic visit setting as a shared decision-making tool that helps the provider and the patients assess and discuss asthma control. Use of the AIRQ in clinical practice could serve to heighten awareness of the need for clinical interventions among all healthcare providers, accelerate the identification of patients in primary care who may benefit from specialty referral, and reveal to those specialists those patients within their practices with unrecognized morbidity. The AIRQ has been validated with a cross-sectional study and a longitudinal study. In these studies, an exacerbation was defined as treatment with a course of systemic corticosteroids for 3 days or more, any visit to an emergency department, urgent care, or unplanned office visit due to an asthma exacerbation, or a hospital stay for asthma greater than 24 hours. The objective of the cross-sectional validation study, as shown on the left of the slide, was to derive the final AIRQ questions, scoring algorithm, and cut points to validate AIRQ as a composite measure of asthma control measured against a standard of the ACT score, impairment domain, plus prior year exacerbation history, risk domain. In the cross-sectional analysis, 442 patients aged 12 years of age and older with physician-diagnosed asthma were included. The patients spanned all disease severities as defined by GINA. The mean age of patients was 44 years old, nearly 30% were male, and over 80% were Caucasian, and approximately 8% were defined as Black or African American. An ACT score of 20 or more and no prior year exacerbation was defined as well controlled. An ACT score between 16 and 19 or an exacerbation that did not require hospitalization was defined as not well controlled. The very poorly controlled category was defined as either an ACT score of 15 or less, 2 or more exacerbations not requiring hospitalizations, or 1 or more hospitalizations for asthma in the past 12 months. The AIRQ questions were then evaluated against this composite criterion to determine its ability to differentiate the 3 levels of control. The objective of the longitudinal study, as shown on the right side of the slide, was to assess the ability of the AIRQ to predict patient-reported exacerbations over 12 months. Eligible patients were aged 12 years of age and older with physician-diagnosed asthma across all GINA levels of severity. A total of 1,112 patients were enrolled, with 1,070 completing 1 or more follow-up surveys over 12 months. The mean age was 43.9 years, with approximately 15% of patients aged 12 to 17 years. Over 70% of patients were female, nearly 80% identified as white, approximately 12% identified as Black or African American, and approximately 6% identified as Hispanic or Latino. Based on the AIRQ completed at the enrollment clinical visit, 35.2% of patients were classified as well-controlled, 38.1% classified as not well-controlled, and 26.6% classified as very poorly controlled. In the cross-sectional study, the retained AIRQ questions were selected for their ability to contribute statistically to one or both of the 2 models shown on this slide. Sensitivity and specificity results from these 2 dichotomous models helped to determine the scoring cut points that demonstrated the ability of the AIRQ to accurately discriminate between the varying control levels. Model 1 on the left evaluated the identification of well control as compared to not well control and very poorly controlled, while Model 2 on the right compared the identification of well controlled and not well controlled against very poorly controlled. In Model 1, an area under the curve of 0.94 illustrates the ability of the AIRQ to differentiate patients who are well controlled from all others. In Model 2, an area under the curve of 0.93 demonstrates the ability of the AIRQ to differentiate patients who are very poorly controlled from all others. The well-controlled versus not well and very poorly controlled model was designed with a focus on higher sensitivity to maximize identification of patients who were categorized as well-controlled and therefore likely not in need of further assessment. A cut point of greater than or equal to 2 yes responses provided a sensitivity of 0.90 to separate patients who were well controlled from all others. Conversely, the well and not well controlled versus very poorly controlled model was designed with a focus on higher specificity to minimize over-identification of patients classified as very poorly controlled and therefore more likely to require intensive evaluations. A cut point of greater than or equal to 5 yes responses yielded a specificity of 0.96 to differentiate patients who were very poorly controlled from all others. It is important to remember that expert reports recommend recurrent assessment of asthma control to ensure disease stability and positive intervention impacts. While the AIRQ has been validated to assess patients at an annual visit with a 12-month exacerbation recall period, more frequent monitoring of asthma control with a validated tool is an important part of patient care. The follow-up AIRQ retains the 7 questions that assess the impairment domain using a 2-week recall, but for the risk domain, a 3-month exacerbation recall is used instead. As shown here, the only changes made from the original AIRQ are to the last 3 questions. Thus, the follow-up AIRQ retains the readability and the simple yes-no formatting of the AIRQ. Now let's dive deeper into the longitudinal study. So how well does the baseline AIRQ control level predict future patient-reported exacerbations? As you can see, the Kaplan-Meier curves demonstrated clear differentiation of time to first exacerbation by baseline AIRQ control level. Compared to well-controlled asthma, the odds of experiencing 1 or more patient-reported exacerbations over 12 months were 2.1 times higher for patients with not well-controlled asthma and 4.6 times higher for those with very poorly controlled asthma. There may be consequences to overlooking the risk of prior exacerbations when assessing asthma control. Among the patients who were rated as completely or well controlled by themselves, their physicians, or the ACT, had 1 or more exacerbations in the prior year. Approximately 5 times more self-rated patients, 4 times more physician-assessed patients, and 3 times more ACT-rated patients went on to experience an exacerbation in the following year compared to those rated well controlled by the AIRQ. Overall, the use of the AIRQ can lead to improved recognition of uncontrolled asthma, providing the opportunity to potentially intervene prior to a future exacerbation. Decreasing severe exacerbations that need treatment with short courses of systemic corticosteroids is essential to mitigate the risk of developing adverse health conditions. Let's now take a look at some of the risks associated with cumulative systemic corticosteroid exposure. With 1 course or burst of prescribed systemic corticosteroid, most regimens will stay under the 500 milligram cumulative mark. However, note that each course contributes to the cumulative lifetime exposure of systemic corticosteroids. In fact, if systemic corticosteroid is prescribed at higher doses over a longer period of time, even 1 burst can exceed 500 milligrams, a cumulative dosing threshold which has been shown to increase the risk of anxiety and depressive disorders and type 2 diabetes. With a second burst of systemic steroid, most regimens will bring a patient into the cumulative dosing range associated with the long-term health risks discussed above, but with higher dose regimens could exceed 1,000 milligrams, which is a cumulative dose threshold that has been shown to increase the risks for renal impairment, cataracts, heart failure, pneumonia, and osteoporosis. With a third burst, most regimens will have reached a cumulative dose shown to increase the risk of adverse health outcomes shown here on the slide. In addition to improved recognition of exacerbation risk, the AIRQ demonstrated better detection of symptom impairment such as daytime and nighttime symptoms, daily and social activity limitations, exercise limitations, and difficulty in controlling asthma compared to the ACT, GINA symptom control questions, and expert clinical assessment. In the longitudinal study, the proportion of patients identified as completely and well controlled but reported symptom impairment was consistently greater with the ACT as shown by the yellow bars, the 4 GINA symptom control questions indicated by the navy blue bars, and expert physician opinion indicated by the gray bars compared to those assessed as well controlled by the AIRQ as shown by the teal bars. This study showed that by using the AIRQ as an asthma control measurement tool, less patients with significant disease burden go unnoticed when compared to the other common asthma control tools. Now, let's look further into how the AIRQ correlates with a health-related quality of life questionnaire. The St. George's Respiratory Questionnaire, or SGRQ, is a validated 50-item questionnaire for measuring health-related quality of life in patients with airway diseases. It consists of a total score and component scores for respiratory symptoms, activity limitations, and psychosocial impacts in the prior 3 months. Scores ranging from 0 to 100, with higher scores indicating more limitations. As you can see, as AIRQ control category worsened, total and component SGRQ scores were significantly higher. These findings reinforce the AIRQ's value, not only as an asthma control assessment, but also as a tool that can help clinicians understand their patients' health-related quality of life. Next, we will take a look at the minimal important difference for both the AIRQ and the follow-up AIRQ. The AIRQ total score responsiveness for asthma control improvement was assessed relative to the minimal important difference for improvement in the ACT, the patient global impression of change response choice of much improved, and the St. George's Respiratory Questionnaire minimal important clinical difference score. A minimal important difference in the ACT from baseline at months 3, 6, and 12 corresponded to a mean decrease of 2.2, 2.2, and 2.2 respectively in the AIRQ. A patient reporting much improvement in their asthma symptoms had corresponding AIRQ scores mean decrease of 2.0, 1.9, and 1.8 at 3, 6, and 12 months respectively. And a minimal important difference in the St. George's Response Questionnaire from baseline to months 6 and 12 corresponded to a mean decrease of 1.8 and 1.8 in AIRQ score, respectively. In summary, a decrease in score of 2 for both the AIRQ and follow-up AIRQ is recommended as the minimally important difference for improved asthma control. Now that we've discussed the AIRQ and the follow-up AIRQ for asthma in adults and adolescents 12 years of age and older, let's shift our focus to an important unmet need, assessing asthma control in children 5 to 11 years of age with a validated tool that evaluates both impairment and risk domains. In a cross-sectional qualitative study, a focus group of 60 dyads consisting of a child and a parent and/or caregiver was convened to elicit language describing the impact of asthma symptoms and exacerbations, and to assess understanding of the draft pediatric AIRQ, which is PEDS AIRQ, questions. The children included in this study were representative of several U.S. populations at highest risk for asthma-related morbidity. 25% of children identified as Black or African American, 32% identified as Hispanic or Latino, and 40% had public health insurance. The 60 dyads consisted of 18 children aged 5 to 6 years of age, 17 children aged 7 to 8 years old, and 25 children aged 9 to 11 years old. The dyads were asked to provide their thoughts and feedback on the instructions, draft items, and scoring of a potential PEDS AIRQ. Overall, parents and/or caregivers reported liking the questionnaire, describing it as straightforward and easy to complete. One parent and/or caregiver highlighted, "I like the questions, it's simple, it's not a lot of questions. I have answered the questionnaires before that were lengthy and very confusing." During the development of the draft PEDS AIRQ questions, feedback from parents and/or caregivers played a central role in shaping this composite tool to be both clinically useful and user-friendly. In terms of clinical support, 97% of parents and/or caregivers reported that the PEDS AIRQ would be a valuable tool to use during healthcare visits, highlighting its potential to support meaningful conversations between families and providers. Regarding presentation clarity, 83% of parents and/or caregivers found the tool's layout and content easy to understand, directly speaking to the questionnaire's straightforward yes or no format. Regarding the design, 81% of parents and/or caregivers said no additional graphics were needed for clarity. Overall, these findings reinforce that the PEDS AIRQ not only measures asthma control, but does so in a way that resonates with and is accessible to parents and/or caregivers. Let's take a closer look at the 60 parent-child dyad focus groups and explore why there's a critical need to improve how we assess asthma control in children. Clinicians were asked to rate the asthma control of these children who were followed in their practices. Additionally, parents and/or caregivers answered the 4 GINA symptom control questions and reported exacerbation occurrence for their child in the previous 12 months. In this study, both control assessment approaches overestimated asthma control in children. The graph on the left is based on a 3-point scale classifying asthma control as well-controlled, not well-controlled, or very poorly controlled. Based on this scale, 48 children, or 80%, were classified by their physicians as having well-controlled asthma. 32 children, or 53%, were classified by the GINA symptom control tool as having well-controlled asthma. However, approximately 1 in 2 children classified as well-controlled by clinicians and 1 in 4 children assessed as well-controlled by the GINA symptom control questions had experienced prior year exacerbations. After the draft PEDS AIRQ questions were obtained, a cross-sectional observational study, which included 399 children aged 5 to 11 years old, was used to derive the final PEDS AIRQ questions, scoring algorithm, and cut points to validate the PEDS AIRQ as a composite measure of asthma control measured against a standard of the GINA symptom control tool score plus prior year exacerbation history. The mean age of the children in this study was 7.9 years. Approximately 63% of children were male, approximately 69% of children were white, and approximately 33% were Hispanic or Latino ethnicity. An estimated 9%, 60%, and 8% of children had mild, moderate, or severe persistent asthma based on pharmacological treatment, respectively. Lastly, nearly 40% of children had public or no health insurance. 18 candidate impairment and risk questions were evaluated against a criterion composite standard of asthma control defined as baseline GINA score representing impairment and chart documented prior year exacerbations representing risk. A GINA score of 0 and no prior year exacerbations was defined as well controlled. A GINA score of 1 to 2 or a single exacerbation that did not require hospitalization was defined as not well controlled. The very poorly controlled category was defined as either a GINA score of 3 or 4 or 2 or more exacerbations not requiring hospitalizations, or 1 or more hospitalizations for asthma in the past 12 months. Based on findings from the cross-sectional observational study, the final PEDS AIRQ questions were established, resulting in a validated composite tool for assessing asthma control in children aged 5 to 11 years old. The PEDS AIRQ is an 8-item, low literacy demand, equally weighted yes-no composite asthma control questionnaire with 5 impairment and 3 risk items. Similar to the AIRQ, it includes exacerbation items that represent a significant component of asthma morbidity and are not captured in common questionnaires. PEDS AIRQ scores are interpreted as follows. Scores of 0 to 1 indicate well-controlled asthma. Scores of 2 to 4 represent not well-controlled asthma. And scores of 5 to 8 identify very poorly controlled asthma. This composite control questionnaire is a tool for healthcare professionals to use collaboratively with parents and or caregivers and their children aged 5 to 11 years old diagnosed with asthma. As with the AIRQ, PEDS AIRQ is meant to be used within a clinic visit setting as a shared decision-making tool to help assess and discuss asthma control. Use of the PEDS AIRQ in clinical practice could serve to heighten the awareness of the need for clinical interventions among all healthcare professionals and to reveal to specialists those specific patients within their practices with unrecognized morbidity. Next, we will look at the sensitivity and specificity calculations which determine the PEDS AIRQ questions and control cut points. As with the AIRQ, the combination of selected PEDS AIRQ items and cut points of control were chosen to balance high sensitivity for identification of well-controlled and high specificity for identification of children with very poorly controlled disease. In Model 1 shown on the left, an area under the curve of 0.86 illustrates the ability of the PEDS AIRQ to identify children who are well controlled from not well controlled and very poorly controlled. In Model 2, shown on the right, an area under the curve of 0.85 demonstrates the ability of the PEDS AIRQ to identify children who are very poorly controlled from those who are well controlled and not well controlled. A cut point of 2 or more yes responses provided a sensitivity of 0.79 to differentiate patients who were well controlled from all others. A cut point of 5 or more yes responses yielded a specificity of 0.95 to differentiate children who were very poorly controlled from all others. Now let's examine how the PEDS AIRQ performed compared with the CACT, as well as physician and parent and or caregiver assessments in evaluating asthma control relative to prior year exacerbation history. As shown on the left, the PEDS AIRQ was least likely to categorize children with a history of 1 or more exacerbations, which is shown in the navy blue bars, and 2 or more exacerbations, which is shown in the yellow bars, as well controlled. And as shown on the right, the PEDS AIRQ was most likely to classify children with these exacerbation histories as having uncontrolled asthma. Those with not well controlled plus very poorly controlled asthma. As we shift our focus to both the AIRQ and PEDS AIRQ, it is important to remember that each is designed to facilitate shared decision-making. The AIRQ is a simple, patient-completed questionnaire that may fit more readily into a busy practice setting than other control tools. The AIRQ can also elicit patient perspectives that can facilitate conversations between patients and healthcare providers, especially around the risk component of their control. The AIRQ, having been validated among adolescents and adults of various socio-demographic statuses, has shown the ability to predict future exacerbations, providing an opportunity at point of care for the patients and the clinicians to potentially intervene and optimize asthma management plans. Since the PEDS AIRQ offers similar ease of use and patient-centric features as the AIRQ, both can be used in shared decision-making to enhance communication between patients, families, and healthcare providers. In addition to the validated versions of the AIRQ and the PEDS AIRQ that we just discussed, further educational materials for both clinicians and patients have been developed as recommended by the external precision advisors. The QR code or website provided here will link you directly to the available tools and resources developed through this program. As a reminder, the AIRQ, PEDS AIRQ, and the Asthma Resource Center are not intended to be a treatment directive, but to support clinicians in moving towards precision medicine in practice. The AIRQ is available in a variety of languages and dialects, which can be produced upon request. Additionally, the PEDS AIRQ is currently available in English and Spanish. For any language requests, use the email address provided to contact our licensing and translation partner. As we come to a close, let's consider attributes of available validated numerical asthma control tools and why choosing wisely may be important. The AIRQ and PEDS AIRQ utilize a simple, low literacy demand, equally weighted yes-no scale compared to the asthma control test and the childhood asthma control test, which employ Likert scales. By including an assessment of risk when determining control, the AIRQ and PEDS AIRQ may help clinicians to better understand the full burden of disease compared to tools like ACT and CACT, which only address symptom impairment. Finally, only AIRQ and PEDS AIRQ include both domains of control, current symptoms, and prior year exacerbation history, which are independent risk factors for future exacerbations. As we conclude, let's review key conclusions from this presentation. The burden of uncontrolled asthma and exacerbations in the United States is high, with projected future costs being substantial. Patients, families, clinicians, and impairment-based control assessment tools may not appreciate exacerbation history-based risk and potential systemic steroid exposure, which contribute to the burden of asthma. The AIRQ and PEDS AIRQ assess both domains of asthma control, which are independent risk factors for future exacerbations. And finally, the AIRQ and PEDS AIRQ can complement current guidelines and facilitate shared decision-making by helping to identify unrecognized asthma morbidity in clinical practice. AstraZeneca is committed to conducting business with the highest standards of integrity and professionalism. If you have any comments that can improve the delivery of our promotional educational programs, please contact AstraZeneca at 1-800-236-9933. This concludes this presentation.
I guess that this is the time to ask a few questions. It's so paradoxical for me because I was one of the lead persons on the team that validated the ACT test and helped to implement it when it was implemented. I think this is a far superior test. If, as you've explained, there are two dynamics that need to be assessed whenever you do these tests. One is obviously the immediate situation. The other is potential situations. And I think that makes this, without question, a superior test. And when we did the ACT test, we knew superior tests would come along. Several have come, but none which addresses these two components. One of the questions I have, is it clear now in our thinking, I know this was debated, that uncontrolled asthma can ultimately lead to chronic obstructive pulmonary disease, which makes this assessment more critical?
I think that's a challenging question. I think we're still trying to get answers to that. But I think more importantly, the value of having an important questionnaire tool that looks at not only symptoms, impairment of those symptoms, level of control, but also looks at future risk of having exacerbations. I think at the core, that's what we really want to know. Are these patients at risk? Even the ones that we think we're assuming are well controlled. Are we wrong about that? Do we need a better tool? Is this a better tool to really look at if there is a risk for future exacerbations, a risk for hospitalizations, ER visits, and potentially systemic steroid use? I think that's the burning question for us, as it pertains now in the here and now, and really helping, having a tool that's just easy to use, but really looking at future risk, and really doing it in a way that we really want, which is not only the risk, the symptoms, but the impairment of those symptoms, but also the risk of what happens as a result of that impairment. I think honestly, having tools that can really not take too much time in addition to what we've already have asked before, which is impairment, but a couple of additional questions that really help us to assess, particularly those patients that may go unnoticed or that we may assume are doing okay, giving us a more precise way. I love the word precision in terms of the consortium that led to the production of these questionnaires, a more precise way to look at symptoms, less control than we ideally want for these patients, and what that all means. It means that there potentially could be a risk for exacerbation, a risk for systemic steroid.
How do these measurements, since they are more subjective, how do they correlate with more objective tests like spirometry, nitrous oxide, and studies like that?
I think it's supplementary. I think it's adjunctive. The AIRQ and Peds AIRQ do not diagnose asthma, but they can help to guide you based on the diagnosis that has been made, which can be, again, from using rule of twos, can be used by assessing spirometry and FEV1 and airway reversibility. It's really nice to know that now we have a FeNO level that we can use to measure airway inflammation in real time. That, this is not to replace the diagnostic modalities, but to be supplementary to asking the appropriate questions so that we can understand impairment and risk. So I think of these as adjunctive and supplementary, but not to replace or to diagnose asthma.
Yeah, I think when we talk about supplementary risk, and I think this is a great test, just to begin with. I have had several opportunities to deal with tests like this. And the question is not so much a question of the value of the test. Okay, let's move to the implementation of the test, which is really where the rubber meets the road. The ACT test doesn't even come close to this. So I want to be clear about that. It's simpler though, So it means it's easier to administer for people who are giving the test. Second thing is, what do you tell if a doctor doesn't have, a primary care doctor doesn't have this structured into his practice? Can this be implemented into the electronic medical record, for instance? And secondly, someone has to administer this test on more than one occasion for it to have real meaning. I mean, so you do it today, you do it in a month, and sometimes that falls apart. And we were never quite able to successfully mount the challenge to get primary care doctors to use it once or twice, then they start to pile up. What are you telling the primary care docs about what they need to do in order to have an effective way to administer and evaluate this test?
Well, I don't think it is a quicker, ACT is a quicker tool per se because it has less questions. It's 5 as opposed to 10. But I don't think it necessarily takes up or eats up any more, quality time out of the practice. And yes, has been a challenge to get any of these questionnaire tools implemented in an EMR. And it really just depends on the EMR. We can continue to try to reach out to our EMR partners to try to get these very valuable tools implemented. It's so important for primary care to have these tools available at initial office visits when they're making the diagnosis of asthma and at follow-up appointments, because how else will they know how to really think about the severity and risk and of asthma and risk of exacerbations for these patients unless they really have a tool, because they are time limited. Specialists are time limited, but primary care is really, really time limited. So maybe we can, make sure that the word gets out that AstraZeneca and the Precision team has published both of these validated tools. One was 2020 and the other was 2025. Getting the word out, I think, is important and key, and making it kind of a fundamental resource that can help us, not limit us in terms of time, but emphasize how it can help us to really treat our asthma patients and identify those patients who are most at risk.
Yeah, well, I think the value of lectures like this fall into maybe 2 major categories. One is to get most doctors to understand that there are 2 dynamics. One is the acute dynamic. The other is the inclusion of exacerbations so that you can protect future dynamics. And if you can get patients to understand that, then it's easier to get them in and to monitor them. Control in patients with a disease that's not constant is I've been in practice like 40 years or so, and both academic and practice. And we can't call it compliance anymore. You have to call it adherence. It's a very difficult thing. And I think that as you spend time, evaluating and talking about this test, excuse my voice, it's almost always like this, but and then I think it's really important for doctors to understand you got to have a system. We've had it in schools where the nurse had to give it or do it. We've had it in lots of different ways. But getting primary care docs to understand that asthma control is not just an observation in your office, or not just what the patient tells you, because the patient wants you to be happy. So how are you doing with your asthma? Oh, I'm doing just great. Well, let's take this test, and you find out the scores are unacceptable. So I think that there needs to be obviously a lot of effort put into structuring this test within the context of a practice which is already, as you would admit, burdened by 100 different parameters on a single electronic medical note. I think that would be helpful. But I think this is a very valuable test. It certainly gives us a little bit more information. I just hope that the primary care community will adopt this test and put it in a framework that allows them to be successful evaluating patients, but monitoring them and anticipating which ones will have real problems.
Maybe we can start at our training institutions, in med schools, residency programs, particularly residency programs for pediatrics, internal medicine, and family medicine. Maybe we can start at the training level, because really that's where they're trained to learn how to screen patients, and and then it's embedded so that when they go out and start practicing, that's their routine practice. Maybe we can start at the teaching level.
Yeah, well, I pretty much exhaust my test. I hate to see my test go down in flames like this, but hey, what's the song say? Everything must change.
Well, change is good. I think they thought it through, and they said, we can tweak what we know to be valuable already. We know that questionnaire tools are valuable. Your test, the ACT test, taught us that tools are valuable. They tweaked it.
And we anticipated that would happen. Anything as simple as we put up there, 5 questions, has got to go down at some point. And I think this is a very valuable addition to the things that doctors should be able to use in terms of trying to keep control of their patients. I tend to use albuterol usage a little bit more sometimes than other techniques, but I think this will be very helpful to us. We have 7 allergists. I bet none of them know anything about these tests, either the ACT test or the other test. And I think it's my responsibility to try to integrate that into our practices.
I agree. Our work is cut out for us, but we can do it. And it's a simplified test. I think patients would be eager to know what their score is,
Yeah.
Is it greater than 2?
Yeah.
And they would be striving the next time they come to our office to see if it's now less than 2. Give them a number greater than 2. That's not what we want. We want something less than 2.
Burnette, I think we could probably discuss this implementation. My grandson is in your practice, and I better get him back over there, because he represents the non-adherent group of people who are kind of hanging around. But I think this is a welcome addition, and we're pleased to have the opportunity to advance the knowledge about the test. And I think that with the audience we have, we probably will change some minds. I appreciate you, and I appreciate the opportunity to talk with you and for you to come on at this time in a very busy schedule.
Thank you, Dr. Lenore, for your leadership and your guidance. And we just hope to follow in your footsteps.
Well, pretty small footsteps now, but we always end our webinars, our programs, with our observation that health is your biggest asset, so protect it.